And Wendy, the floor is yours.
Great, thank you. Hello, everyone. My name is Wendy Wisdom. I work for the Indian Health Service Office of Information Technology. I'm a social worker. I'm an MSW who somehow became an IT specialist. I don't quite know how, but I've been working with IHS for 23 years. I got 7 more years till retirement. I am the federal lead for the behavioral health system, which means I oversee all the software development. I do the testing. We do the deployment nationwide to all the sites, and I do training and user support. So if you do have any questions, issues, or training needs, I would be your point of contact. But you can also, if I'm not here, you can also reach out to the help desk and submit a help desk as well. I also do other tasks. I'm currently working on social determinants of health, the new things for the USDI version 2 and 3 certification. So that's another project I'm working on with the 40H Health Information Exchange, specifically related to behavioral health types of data, specifically 42 CFR data. So there's other projects I'm working on, but my primary role is being the support, the main federal lead support for the behavioral health system. So as mentioned before, we did go over the data entry. Basically, how do we get the data in? How do we do the clinical documentation into the system? And what's great about that is if you can get that standardized and being entered into your system by your clinicians, then you have the option and the power to pull the data out and to run reports, to see workload, to see maybe there's a need for training and crisis intervention because we've seen an increase in that in the past 3 to 6 months. See if there's a need for a youth group. Maybe the target age of the people you were seeing are adolescents, and maybe you need to provide more targeted services towards them. So you can really use this data to look at what types of services increase or modify, do grants, hire new staff, as well as look at, our usual workload and productivity and such. So today we're going to just go through reports, obviously, but I'm going to do I have a slideshow basically kind of doing some reminders of installation and setup activities. Most of you probably have already done this. If you come on board as a department chief, or if you're supporting the IT system, maybe just double check that everything's already set up and installed and done completely. So this might just be a reminder to check on it real quick. Also knowing what the manager utilities options are, what's available to you. You may never have a need to use them, but just knowing they're there is also a good thing. We'll also talk about the national monthly exports that we ask everyone to do. It's basically generating your local data into the national data so that we can then use that data to report to the Senate and Congress on why we're seeing an increase in this or a spike in this, and we need more funding. But that's basically where we're documenting and asking for more funding a lot of times with that data. But we want you to be represented. We want your population to be represented. So those exports are really important. And then, of course, the primary thing is just how to run local reports. So as a reminder, we are currently on, it's called the Behavioral Health System, but what we call a namespace. Every RPMS application has a 3-digit namespace, 3 or 4 digits, and our namespace is called AMH. So it's the AMH version 4.0, and we're on patch 10. Patch 11 should come out sometime before the end of the year, and that will have the new changes to the DSM-5 TR codes and some minor fixes that we have coming in the next patch. But currently, the released version is patch 10. There is a document if you are a brand new site, or we do recommend looking over something called, it's a document, job aid called Behavioral Health version 4.0 issues considered before installation. Again, most of you have already installed it, so it's a non-issue. But for those, if the case is anybody who hasn't done it already, that's the document we would help you review before you go live. And again, as I mentioned, contact me or the help desk, and the help desk is at itsupport@ihs.gov. So when you're first starting the system, just some of the activities we tell you to do, and it just makes life easier. And if you haven't done them, maybe think about doing them. For every person that's going to access the system, just make sure there's little desktop shortcuts on your computers so that they can just double click. There should be a shortcut to the GUI, which is what we kind of did last time, and then some kind of terminal emulator application. Running reports is in the background in RPMS, and you have to use a terminal emulator application to get to those reports. And I recommend, they do require a licensing fee. Sometimes the area has them, and sometimes your site pays for them. But definitely having access to that terminal emulator could be NetTerm, TerraTerm, Koala, TVNT. There's lots of them out there. But it makes your running reports a lot easier. And just having the icon on the desktop is easy for clinicians just to click on if they need to run the report. Making sure they're set up correctly, that the user setup's done and they have secondary menus. Security keys. If someone tries to run a report and they can't, that's because they don't have the security keys. So if you feel like there is a need for that person in their current job position and their role that they need to run reports, you need to assign those security keys to them. Definitely review your site parameters and defaults. Make sure they're set up correctly. If you don't know how they should be set up, give me a call, give me an hour, and you can show me your site parameters and I can say, yep, looks good, or maybe you want to rethink this or consider this. So, but definitely if you want to review them, give me a holler and I can do a call with you. Your network configuration connection, that's just when you do your monthly export, it's deciding how you wanted to send your data to the national data. Does your area office want it? So maybe you send it both to the national and your area. It's just configuring your connection when you send your data. So that's something that has to be set up. And then making sure your clinicians have their electronic signatures established. That should be, again, some part of the new employee orientation when they get onboarded. Finally, talk about, how are you becoming paperless? If you are, again, a brand new site, at some point you're going to stop doing paper documentation and do your clinical documentation in the system. What's your policy? What's kept in the system? What's kept still in a paper document? How are, release of information done? All that kind of fun stuff. So there's a workflow process that might have to be modified a little bit once you start documenting in the system. As for the site parameters, pretty much most of them are optional, but there are some that are required. The ones that are required are these ones. I'm not going to go into big detail about these because, again, I would assume most of them are already set up in your system. But if you do want to take a review at those, you can call me and I can go one by one and just see how your system is set up. But these are the minimal site parameters that have to be set up for your system to work the way it should. The security considerations, actually, you know what? I'm going to go back real quick. One thing I wanted to mention, in the site parameter, if you run a report and you see no data, because I get that call a lot of times. Wendy, I gave myself the security keys, I ran the report like you trained me, and then I still don't see any data, but I know there's data. In the site parameter, you have to go put someone's name in this where it says, whoops, it says update those allowed to see all records. The system is designed for you to see only your documentation where you're a provider. So part of the new employee orientation, I would encourage sites is to add every single new employee onto that list to allow them to see all records. So that I won't only just see the visit records of my clients or where I'm a provider, but if I have to cover for so-and-so, and I can see their records, or if that case gets transferred to me, I can see that person's previous documentation by another provider and then see mine. So really, even though the system was designed to really lock it down, we have more of an integrated process where there is a need to know to share that information. So I would think that most people are allowed to see all records. Now, if you have a student, a volunteer, someone that you feel like, nope, they shouldn't see everything, they just need to see what they do, then you can keep them in that kind of restricted mode. But this will affect reports. So if they're not on this shared see all records, they will not see any reports other than visits of their own. So that might be another troubleshooting If you try to run reports, you get 0. One of the things I would recommend is go to the site parameter, go where it says update those allowed to see records, and make sure that person's name is added there. This is just when you get set up. Behavioral health providers are normally the people that are given the behavioral health security keys. You might decide to give other people security keys, but someone should be the gatekeeper or who gets access to these keys. There's secondary menus, and if your IT people ask you, those are the 2 secondary menu keys they have to have. And if anybody has divisions on their database, there is a way to lock it down to see only visits in a specific division through the UU option. If you do have divisions and want to be able to do that, give me a holler and I can walk and talk you through it too. Not most people have divisions, but I know there are some sites that do. These are the security keys in the behavioral health system. I do not recommend giving all the security keys to everyone. I feel like there's a need to know. So the ones, there's like 4 of them that have asterisks: the menu, the data entry, the health summary, and the suicide forms. Minimally, that is what a clinician needs. They only need those 4. Anything else, if you need to run reports, then there's 3 report keys, I'm sorry. There's this one, the AMHZ RPTS, the DV reports, and the suicide form reports. So you can choose, do they just need the reports, or do they just need the DV reports, suicide reports, or do they need all of them? So that would be your decision if you want someone to run reports. What keys? Do you give 1 or all 3 of those keys? That's up to you. And then again, there's keys. Nobody really can delete a record unless they have delete keys. This coding queue is for coders. And the manager key, some people might have it, IT people probably have it, but it basically goes back to what's your role, what are your duties, and then do you need access to these keys. In the user manual, there's a definition of all these keys, but you can always give me a holler if you need more explanation on the specific keys and what do they do. Okay, the manager utilities option menu. Again, you have to have a security key to get to this menu. But once you have that key, you do have the ability to review or modify the site parameters. You have the ability to go and send that monthly export to the national database. You could run past reports or error reports as well. You can add and edit local service sites. So if you wanted to put in, I don't know, a community center or a high school, some location that you go and provide services and you want to add it as a local service site so you can use it for documentation and run reports. You can create your own list of local service sites. Patient flags, if you started using flag number 1 to mean homeless and you decide, well, that really doesn't help, let's reset that flag and use it for something else. You can come and reset a patient flag if you're using it. Editing a record. If you feel like there's a time where something's a record, you feel like I didn't type that, someone went and edited that record, you can come and view that record to see who edited the record. This is where I caution you that do never enter a record in edit mode unless you're meaning to edit it. If you want to look at a record, use view, do the view option. But if you go and you edit a record, you go into that mode of editing. And even though you don't change a single thing, but you hit save, it's going to log you as having gone into the editing mode and exiting the editing mode, even though you did nothing. So just be cautious that when you look at records, just use the view option and don't go into an edit mode unless you're really going to edit that record, because it captures you in this report. Personal history factors, again, that's a table you control. So if there's any unique factors of, I don't know, they were adopted into a non-Indian family, or maybe they're a survivor of 9/11 or something that's just a historical fact, but you want to track and run reports on, you can create unique personal history factors and track it through the behavioral health system. I will show you how to customize and create a custom report. And if you create them, you want to delete them, maybe I'm going to retire and I want to go delete all the custom reports I created, I can go and delete all the reports I created. So it's just a way that you have don't be afraid to create them, because you can go delete them as pretty easily. EHR problem crosswalk. There are some EHR, if you have a database that has EHR, those visits from EHR are passing over to behavioral health. Sometimes there's ICD-10 or SNOMED codes that don't map to a DSM code. So we have to create a crosswalk. It's an optional, if you want it to fit into a nice category, you can create that crosswalk manually. Some sites do it, some sites don't, but it was a request that some site requested us to create so they could do it for all the codes that don't map cleanly over to a DSM diagnosis. So we created it, but it's not essential that anyone does that. And the last one was that UU option, updating locations a user can see if you have multiple divisions on a database. So like I said, chances are you may not need to use any of these manager utility options. If you have the keys, great, you can go in and use this functionality. If you don't, at least you know they're there. And then you can go ask somebody in IT or someone to say, hey, I know there's an option to go look at it, who edited a record. Can you please pull that up and look at this record for me and see who edited it? So at least you're aware of what's available to you. When we talk about the exports, so again, this is a separate export from the PCC or what you hear, the National Data Warehouse, NDW export. It's separate. And it actually still needs to be completed even if no one is using the behavioral health system, because there's the suicide forms that only live and store in the behavioral health system. They don't get stored in EHR or PCC. So that's where we tell sites, all sites, you should be running an export. Typically, they're done monthly. You can do it manually. I used to do it manually on the first month at 8 o'clock in the morning, but you can also work with your IT people, and it can be created as a task man routine to run it automatically at 3 a.m. on the 31st, the last day of the month, something like that. It can be run. If you want to see if your site is exporting, you can go to this website, and it has all the exports we receive from the different areas and locations. And yeah, if you have any questions or if you've never sent an export, you can also call me, and I can walk you through how to do the export. And if your IT people want to be shown how to set up the task man, I can show them how to do that too. Okay, so basically we took care of the site parameters, we talked about the manager utilities, and we talked about the exports. So now we're really going to be focusing on the reports. Basically, for behavioral health type reports, there's two applications where you can run them. The first one, obviously, is the behavioral health system, which is, again, our namespace is AMH. There's another system called the PCC management reports, and their namespace is APCL. But those are the two places you're going to be able to run reports depending on the type of reports you want. So when I ask people, I say, what is it you want to run? What kind of data are you trying to pull? And then I can give you a recommendation of where is the best place to run it, and maybe I can even tell you which report will help you the best. So that's where kind of like I can help you. I can't help you get access to them. That's a request that would have to come through you or your supervisor to request and justify why you need access and those security keys to run the reports. Hopefully they give them to you, but I can't force sites to give you report keys. But once you know somebody, if you get them or if you know somebody who gets them, then you can ask them to run this kind of report and data. Sometimes I tell people you have to run a couple reports to get the data that you need. And then if you want to do it, like comparison of like a timeline month to month, and then you're probably going to have to run it every month and then put it on Excel so you show the graph kind of thing, and show the clinical trend and is it increasing or decreasing, all that kind of fun stuff. So sometimes it's a little bit of creativity of trying to, how do I display the data in the best way in my monthly report or to a reporting, a governing board or to a conference. How can I show the data so it's more easily understood? So in the behavioral health system, we have, there's two places where the reports are. One is in the data entry menu. And anybody with data entry keys, which is basically every clinician, you guys have access to those reports. Then there's reports a reports menu, and that is held by those report security keys. And again, so once you get those keys, that menu will show up in your system. We do have reports called canned reports that basically the logic is already built in. Somebody told me to create a report, and then they wanted it in this format. So I created a canned report based on what they told me to do. And some people use those, and that works for them. If you can't find the data out of one of our canned reports, then there's also reports called PGen and Gen, and it's patient general retrieval and visit general retrieval. Those are more customized, and those are the ones that you can kind of say, well, I want females from 18 to 65 that live in this zip code with the diagnosis of depression that have been seen in the behavioral health clinic. You know, I mean, you can kind of put all these different data elements, and I can create a customized report. Those are going to be the ones, the PGen and the Gen are going to be the ones that you would do those that don't fit into the canned report. So behavioral health reports, there are no reports in the GUI, the graphical user interface that we showed you how to do the clinical documentation. All the reports are what we call in the roll and scroll environment of RPMS. And this is a screenshot of kind of what it looks like. We have about 70 reports in behavioral health. Again, most of them are canned, but you do have the Gen, the PGen, and the list that have more customization available. This screenshot, it's from an old one from patch 7, but it has patient listing reports. They have the behavioral health encounter where the Gen and the list, the customized ones are, workload reports, problem-specific reports, and then there's a table just to print tables, which most people don't use. So, but that's kind of what it looks like in the database, which we'll get into shortly. So in addition to those reports, those 70 plus reports that we have in behavioral health, then there's PCC management reports. And this is where suicide reports are there, screening reports are there. But there's also, if you're looking for more reports like how many people have diabetes, but also have a co-diagnosis of depression, or what kind of medications are being treated for, or what are our top 10 medications that our behavioral health clients are using. You can do reports like that because PCC is where all the data kind of flows to. So all the data from the lab package, the pharmacy, from EHR, from all the different applications, they all flow to PCC, and even the behavioral health data flows there. So that's why you're able to run reports that involve some of the other applications, not just the behavioral health documentation. So sometimes it's just trying to determine, is it best to run a report in PCC, or is it better to do behavioral health in terms of pulling out the data? I will tell you, when you run reports, there is a learning curve. So the roll and scroll is command prompt. If you're kind of older like myself, we remember kind of doing DOS where you command prompt. You don't use your mouse or browser. I used to take them during the trainings. I used to unplug them and take them away. And I tell people, you have to use your keyboard. You have to type and hit enter. You have to do it as commands. So that is a learning curve. Some people find it easier to do, some people find it very frustrating and then just give up running the reports. So I recommend finding someone on your staff who is familiar with this kind of a database, and maybe just a little bit more efficient to then make that the best person to run your reports. I do again recommend using a terminal emulator application, and that allows you to also capture the report into like a word processing application, or even throw it in Excel. I can show you a quick demo of that, of how to do that. It makes life a little easier. Just a reminder again, you may have to run more than one report to get exactly at the data you're wanting. And don't get frustrated, keep practicing. I would recommend whoever runs these reports, you need to run them consistently. If you run them once a year, you run them quarterly, you're going to kind of forget. I have one person who has to run it every quarter, and she calls me every 3 months. and says, can you walk me through that again? And I'm like, you need to run this every month and practice more, because you're forgetting how to do it. Even though she's written the steps down, it's just something that you got to kind of keep doing it. Otherwise you forget how it works. Okay, and here's just resource information, listservs, websites where the manuals and all that kind of fun stuff is done. Let me get into the demo. And again, this is my contact information. It's real easy, wendy.wisdom@ihs.gov. You can email me, and I pretty much have no backup. So even on vacation, I'm still following up on emails and looking at my phone. Okay, so I'm going to stop this and get into my database real quick. I hit the wrong one. Let's see. Okay, make sure I'm sharing again.
Yes, we can see.
Okay. So what I'm doing is I'm getting into, if you guys don't know, I telework. I'm a headquarters employee, but so I should be in Rockville, Maryland, and all my contact information is Rockville, Maryland, but I actually live in Oklahoma, in Thackerville, Oklahoma. So what I do is I do a VPN net connection to a database in Albuquerque. I believe it's in Albuquerque, and it's our training database. It's a development. We do some testing and so forth. So I'm just remoting and desktop to a remote desktop in Albuquerque to the system. So here you can see is the behavioral health GUI where we would go in for doing our clinical documentation. I'm going to go to the terminal emulator. So for this database, they're using a software called Secure CRT. But again, there's lots of them out there: TerraTerm, NetTerm, Koala, TVNT. I know I've used about 5 different ones. So they're all pretty similar. When you double click it, it will open up, and it basically is telling you, okay, well, who do you want me to connect to? It's like a phone. I got to dial or connect to somebody. And normally you can kind of keep your people that you connect to over here, so you don't have to type in like file and connect and type in all the information. Normally they kind of have once you've connected successfully, you can just click on here. So this again is it's a fake database that we use for headquarters, and then it's going to have the access and verify codes that you probably use, just the same ones that you use in the other system. So let me remember what my codes are, and I have to hit enter. Okay, so let me see if I can make this a little bigger. Is that a little better?
Yeah, that looks good. Thank you.
Okay, so again, it just connected me. I did my access and verify codes, and it gives you the okay, you're entering a government system, blah, blah, blah. And then it tells you, good morning, Wendy Wisdom. The last time you signed on was July 29th at this time. And it's telling you return, enter to continue. So it's commanding you to do stuff. So, okay, I hit return, and then I get to my menu. This tells me there's a mail message. Before, again, this is how old the system is. Before there was Outlook and email, we had to do emails through this system. So they still have the email system going, and I get emails through here, which it's a fake database, so it's not real stuff. But yeah, we used this before we all had Outlook emails. Okay, so what it did was it took me to my main menu. You actually would not see this because I'm an IT person. I see all this stuff about Taskman security, all this monitor stuff. You're going to go straight into the core menu. So it's asking me select an IHS kernel option. So it's telling me to select one of these options, and I'm going to take it into I can do one because it's the IHS core, or I could actually type in IHS core, and it takes me into the IHS core menu. So that's what normally when users are set up at a site, they're taken straight into the IHS core menu. And normally your menu is pretty small because you're only given access to the applications that you have a need to know. Again, this is a training database and I'm an IT person, so I have access to every single application in RPMS. So your menu will not be as long as this. It's just because I have all the security keys that's why I have such a long list. But what you're looking for is you're looking for this. You're looking for the behavioral health system, information system, and it'll have an AMHS or sometimes I've seen it as B8, sometimes I've seen it as MH. Every system might be a little different, but this pretty much is the same. It always says behavioral health. So when I look at this, it continues to tell me return to continue or do the shift 6 to stop. If I do shift 6 to stop, then it tells me select one of these IHS core options, and I'm just going to type behavioral health or just behavioral. And that takes me straight into the behavioral health system. It tells me I'm in the behavioral health system version 4, patch 10. This is my demo hospital that I'm in. And then it tells me I have security keys for data entry, reports, and the manager utilities. So the data entry reports, remember I told you everyone's going to have this first one because basically they need to give you those keys to do clinical documentation. So in data entry, basically everything you could document in the GUI, visits, group entry, treatment plans, suicide forms, anything we can document there, you can document here. The only difference is here you can go to DSP, display record options, and I can see there's things I can list visit records, I can print encounter forms, I can list of these are reports, list of no-show visits for one patient, list of visits for unsigned notes, and then there's the GAF and PHQ2, PHQ9, GAD scores for one or multiple patients. So I did tell you that there are some reports you can run without getting any security keys. The one I would encourage you to pay attention to is this one. Out of all of these, is this one. So I would recommend someone in your program, it can be the program director, it could be the administrative assistant, somebody run this just to see if there's any notes that are still not signed. So you can, every report, these are the canned reports, they're going to show you a title, they're going to show you a brief description, and they generally start with a start date and an end date. So I'm going to go, I don't know, I'll do a year, T-minus 12 months. And you can see I abbreviated it. If you don't know what to put, you can always do 2 question marks, and it shows you, okay, well, what's an end date? I don't know what to put in. It'll say example of valid dates are. You can do the month, year, you can do the slash marks, the 6 digits, or you can do what I did. Today minus 12 months. Today minus 3W, which is for 3 weeks. So there's kind of little ways to kind of abbreviate it to make it less typing. And as you do more reports, you kind of remember, okay, it's easier for me to do this. But if you want exact dates, then you're going to have to put it in one of these formats. Okay, so basically I'm doing a year report. So I'm starting with August 2nd, 2021, and I'm ending in August 2nd, 2022. You can choose one program or all programs. I'm going to choose all programs, and I'm going to choose all providers. How would you like it sorted? I'll sort it by the primary provider. And then I'm going to include all patients, but you could exclude or exclude demo patients. And then I always browse. If you print it, it's only going to print to the printer you're sending it at, or you're going to print to your screen. But I always like to browse it, look at it first, and then if I want to print it, I can print it from browse. So here is my report, and that was really fast, right, for a year of data. It says there was no unsigned encounters for this time period. Okay. So I'm going to try to do another report and see if I can't find errors. Let's do 36 months, do a few years. Include all patients and browse. Oh, I just meant not have any errors. What it would normally say, sorry about that, I guess I don't have any. Oh, I could do one real quick, let's see. Let's do a group. Give me 2 seconds. Today, no. The test, 14, 12, the I don't know. That's fine. Okay, demo 1. Okay, so now let's see if I run that report. QP. Okay, EF, CT, A, R, Brown. Oh, it still didn't show. That's all right. But it normally would show a patient name, it would show the chart number, the date and time, the provider, and it would basically show these encounters have not been completed. They're incomplete. They have not been signed. Once they're signed, they're completed and finished. And then this only tells you what the program is, if it's mental health, substance abuse, or, chemical dependency, or social services, and then if it's a group note. So that would tell you where to go look, if it's an individual note or if it's a group note. So that should have shown up. I just didn't do it right to show up as a group note. But if you run this and it says no encounters, everything's good, then you know everything's good. But I would say run it at least monthly, if not quarterly. That way, if for some reason there's visits that haven't been completed, you can go follow up with that provider. I would also run this report before someone leaves. Running this report to make sure, hey, before you leave, all your records are signed and completed before we check you off and do your closeout. That would be another report that I would encourage you to run. So again, those are kind of the data entry reports. When you go into the main reports menu, you do have these other patient listings. So let's go into patient listings. Again, there's 70 reports. We won't have time to do all of them. This tells us if you're using that designated provider list, it'll do a report of all the provider caseloads. I can see patients sorted by age and gender. I can see no-shows, placements. If you're doing the placements by site, there's expert reports, screening reports, training reports. Anytime you see ... that means there's more reports in that. So I can put case, and then it'll tell me that there's more reports here, cases opened but not seen in this many days, like if you need to close them out, maybe they haven't been seen in 90 days. Duration of care, open and closed cases. There's the screening reports. So there's screening, and these are tied to GIPRA. It has the GIPRA logic of domestic violence, intimate partner, the alcohol screening, depression screening, suicide risk. The new, in the next release, you'll have the suicide screening reports that will also be here. But they're all listed under the screening reports. But that kind of gives you an idea of the different type of patient listing reports. You have the record reports, and again, I mentioned these are the two that you can kind of customize. The workload reports have basically activity reports by provider, frequency of activities, prevention activities. The fact report, I think, is helpful for some programs. They like to know what are we spending our time doing mostly. So I might see what, I can do a list. I'll do 50, include all, and browse. And then it will just show you what are the activities we do. So if this was a real site, it would show group activity is our #1 activity that we do. We do behavioral health, individual treatment counseling. We do so many assessments, case management, crisis intervention, screenings. So again, it's just sorting the activities that you're doing in that date range. It has the activity code, the records, and how much time and hours that are spent on those different services. They do have the ACT report is kind of the most frequent workload report I tell people to run, because you basically come in, I can do it by provider of service, do the date range, and then I'm just going to include all patients and browse. And then it just sorts it by the provider. And again, this is a demo database, so it has only a few of us. So if I saw this, I would say, hey, there's an error. This person wasn't set up correctly because they don't have a discipline. But it has Ryan, who's set up as a psychiatrist, someone else who's set up as a behavioral health, probably counselor or therapist, and I don't know what I'm set up as, mental health therapist. How many records, how many patients, how many activity time, and that date range. So again, that's the most frequently workload. Now, what I tell people though is when you run that report, it's going to capture all records, all kinds of work. So be specific. Do you want anything they do? Do you only want telephone calls? Do you only want face-to-face ambulatory outpatient encounters? Do you only, do you want records on closeouts, discharge summaries, records, documentations, faxes? I mean, people can document especially if you're doing case management. I can say I called the patient, left a message. That's a record. If I said, okay, I faxed the application to the YRTC for possible admission, I can document that as an administrative record or, case management record, and that's a record. So, that's where I tell people when you're running the workload reports, do you want everything, which is easy in what I showed you, or do you really want it just like for billable services? Well, then that's going to be outpatient ambulatory services. And then I would have to I'd have to run the same report. I'd go to ACT, I'd do a provider of service, do your date range. And then here, I might need to go and say, I only want the outpatient, which is 42. And I'd have to tell it, I want outpatient only. And then that would take out all the other telephone calls, the other types of services that we do. And then when you do that, your numbers will probably be a little lower. So that's where sometimes, again, trying to know what you're running and how specific you want to get, or how you want the large picture, or do you want it more detailed in types of the report that you want. We do have problem reports. So problem reports also do the frequency, just kind of what's our top 10 diagnoses, things like that. Actually, the FDX does it, but I like the FPRB. So I like this one preferably. The first one does the diagnoses alone. So every diagnosis, every depression diagnosis is going to stand on its own, where the SPRB kind of lumps all the major depressive disorders. It lumps all the alcohol use disorders. It lumps those different, if it's mild, moderate, it kind of lumps them together rather than separating them out. So that's why I find it a little more useful for me. And when you get to browse, you can always use your down arrows. You will see in the browse mode, it says enter 2 questions for more actions. So remember, when you don't know, you just enter 2 questions and then it will tell you, do you want to go to the next screen? Do you want to go up or down a line? Do you want to print the list, print the report? You do PL. You want to print the screen and then you tell it what printer it wants to, or you want to get out of it and just quit. You cue to quit. So if you never know what command to put in during this browse mode, just do 2 question marks and it'll show you the options. So this is where, like I said, it kind of lumps in the depressive disorders, drug dependence, alcohol abuse, anxiety disorder. It kind of lumps them together to give a bigger one. But if you prefer the actual diagnosis separate, then go back to the FDX. I do primary and secondary because I want both of them. And so this one you can see is a little different because it's actually got the specific diagnosis and the code. So it just gives you choices. You know, once you do get the reports keys, I do recommend just getting in there and playing around a little bit and seeing what else can you do? What does this one do, kind of thing. When you're first starting, keep your report short. Keep it like to a week, a month. I wouldn't go in and run a 5-year report. That's going to be a really long time, to pull that data for 5 years, but keep it smaller. If you're going to be running those bigger reports, running them when there's less people on the system, so it won't slow the system. Sometimes I would even come on the weekends or do it in the evenings when everyone's gone home to run some of those bigger reports. So those are the behavioral health reports. I can take questions, or if there's some you want to see right now, I can run those reports, or I can take you into PCC management reports and show you those. Do people know what PCC management reports are? Have you guys ever seen them? Because maybe that might be the way to show you.
Yeah, I think we might want to go check those out.
Okay. Just, again, it's a play database, and at least you would know what it is. So if you're going to get out of behavioral health, the easiest way is just to hit enter. So I'm going to hit enter. It takes me back to the previous menu, which was my behavioral health system, and I'm going to hit enter again, and it takes me back to that IHS core menu. In the IHS core menu, you are looking for this one. It's called the APCC patient care component. That is where your PCC management reports are going to be. So again, one, you have to have security keys to that database and to the reports, and it would show up on your core menu. And then you would just type in, I'm just going to type in patient. And there's 3 of them that start with patient, so I just want the top one. And for this database, it's right here. It's called the MAN. The abbreviation is MAN-R, but they're called PCC management reports. And so that's what we're going to go into. Okay, so for PCC management, these are their categories. In behavioral health, we only saw there was kind of like our patient listings, our workload, our problem. But you can see for PCC, there's many more different ones. They actually have certain reports just for meaningful use. Remember or inpatient reports, billing reports, body mass index reports. So again, we're talking all the medical type reports as well, not just behavioral health specific. But they have something similar to us, like, patient listings. So if I go to BLST, then it has a PGen like we do. It's also got like tally of elders, screening reports, suicide reports. It's got different reports because it's pulling from different applications, pharmacy or patient reg, ADT, things like that. So we have different prescription cost report, things that we wouldn't be able to do in behavioral health. I do see a hand, and I'll look in the chat.
It's this is Keisha. Wendy, I was wondering, is there a way, or is there like a guide or a document that kind of has like all of these, like a full list of all of these reports and kind of like under what circumstances or reasons that you would run them, that's like outside of the system? Like, is there like a printout or anything available?
They do. They do have on the website, and if someone wants to read it, by all means, you're welcome to. I will tell you, they're not, because I mean, basically, you've told me to, someone told me do a user manual that has 70 reports. And so there's instructions on how to do them, but I don't find them very user friendly, but we had to have them. So if you go to RPMS management, let me look real quick. Each application has basically a user manual, if that makes sense.
Okay.
So, so if you go to behavioral health, you can go to user manual, and it has it. Same thing if you go to PCC. Where's theirs? PCC. I don't know if it's in their PCC one or if it's APCL. Let me just think. Theirs might be, they may not consider that clinical, they might consider it administrative because it's reports.
Okay.
So APCL, bounce benchmark, general retrieval, nope, infrastructure, APCL. Nope. So I would think it's in PCC then. If they don't have their own, it's got to be then in, oops. I would think it's probably just in the PCC. I wonder if it's in PCC data entry. I don't support PCC, so that's where I'm kind of like, oh, they should have it. Every application is required to have it. So it's just a matter of where it's located.
Okay. And then outside of like workload, the workload report, are there any reports that you would recommend that clinics are running regularly to ensure patient care?
I think it's helpful to run. So when I did, see, and this is where it comes like what's important, I know the reports I used to have to run, they trying to find one. So this is how old, this is from like 2004 when I still worked at the hospital. I had to do like a thing on accreditation report. How are we doing? What's our accomplishments? The staffing. But all the data that I would get and trainings and visitors and future goals. So I would run our workload. I would run our workload. I would run it. I would also run third-party billing to say what was our reimbursement collections and how many of our patients had alternate resource and stuff. But this is what my leadership requested me to run. So that's what I had to run. But other people, it just kind of depends on if you're looking to increase more staff, looking at what your workload is, looking at what are your diagnoses, what are your services? Are you doing more med management and you need more psychiatrists to do that? Or if you don't need a psychiatrist, maybe a nurse practitioner or a PA, someone that's licensed to be able to do the medication. So it kind of just, but most of the time it ends up being the workload tends to be the most. The workload and the error reports are probably the primary ones that I encourage you to do. And then whatever your leadership and administration also requests. You could also run age and gender to make sure there's competencies. I know every year we have to renew our competencies. Is it age appropriate, culturally appropriate, all those kind of things. So that might be another report you run annually. As a list of possible reports, differences they should run. Okay, I think that was your question. Okay, so you wanted to see a customized report. Okay, so let me get out of PCC, but just to show you, there's lots of PCC reports. The other ones I would look at maybe is the quality assurance reports in PCC management. They have, this is kind of clinic visits by count, listing of visits, provider counts. But you're gonna, when you do these, you're gonna do the whole hospital, their whole clinic, because it's for all the providers. It's not specific to just behavioral health. So that's where these tend to be, they could be more detailed, but they include the medical documentation and all the medical providers. So that's why these reports tend to be bigger than the behavioral health specific ones. But let me get into AMH. So someone asked me for a customized report. I'm going to go into one of the reports that I like, that I used to run is the list, because it's already pre-formatted. You basically can customize what you want from it. So I'm going to just do a couple of years. So your first visit, your first menu selection always asks, well, what kind of visits do you want? Do I just want substance abuse clinic visits? Do I just want visits by Wendy Wisdom as a provider? Do I want just visits that have a diagnosis of this? Do I just want female patients? So you can make any of these selections. And if you ever want to print this out, just do a PL and again, print it to your printer, but it'll print this list out. So then you kind of have a list or a cheat sheet to see, well, what are, I could, you know, just want the ones that have Medicaid, that just have an outpatient, just have a diagnosis or a score on a screening. What's the result? Positive screenings on alcohol, something like that. But if you don't want, and you basically want all visits, then you make no selections and you just queue to quit. And that's telling the system, I want all reports, all visits in that date range in behavioral health. And then you can say you want detailed or brief. The brief one is easy because you can, it's already pre-formatted. And then I can say I want to sort it by, I don't know, I want to sort it by the type of contact. So let's do 31. Do you want a separate for each one? No. Include all and browse. So this is just, it's already pre-formatted, but it tells me a list. And there's a lot of information you get on this. So I get the date of service. I get the provider's initials, so I know who the providers, where the location is, which ours is a test database, the patient's name, the activity code. So I know these were 11s are screenings, 12 was our assessment. If you start memorizing the activity codes, you start remembering what these are. What the contact, whether they're administrative, chart review, outpatient, how much minutes, 5 minutes, 120, 60, the chart numbers, the problems, the diagnoses, and then the narrative of the diagnoses. So it's a neat way to kind of look at a whole bunch of visits in a date range at one time. And you can, I think I sorted it by the outpatient or type of contact, but you can sort it by diagnosis, by patient name, however you wanted to sort it. If you don't like that format and you say that's too busy, that's too much information, you could have just said, I want to do the same date range, but I'm going to still pick all the visits, but in this one, I'm going to do a detailed. So this one, I'm going to tell it what I want. I want to sort it by, let's sort it by date, encounter date. No, include all patients. Browse. Oh, actually, I think this one did it differently. It still gave me, but it just went to a longer report. It gave me, instead of scrunching it up, it gave me all the same columns, but it went out all the way. So it kind of shows it. And you can see I'm going to the right. So it would be a longer, you would almost have to do a landscape type of report because it went to the right and it shows it all. Let me show you the custom. So let me do the gen. The gen's a little bit more customized. A date range. B minus 24 months to today. So let's pretend I'm going to do that report where I want to see what are the alternate resources. So let's say I'm going to take all visits, but I want a detailed report. And then I have to decide what do I want printed. I could do patient name if I wanted. I could do their chart number, which is number 8. So you're looking up here, patient name is number 1, patient chart number is number 8. I could do, I can see, that's going to tell me, are they eligible or not? Medicaid, Medicare. I don't know if they'll do that. Let's try that. Let's try to see if I can do, we'll do 16, 17, and 18. Okay, let's see if I can do that. So then I have to give it a command, select, and then put those numbers. And you put it in the columns that you want. So I want the patient name to go first, which is 1. The chart number is 8, and then 16, 17, 18. And then it gives you suggested, like, how many characters for each column. Let's do, okay. So now that I'm done with that, I queue to quit it. And let's sort it by, we'll do 12. Okay, so now it says, do you want a separate page? I say no. Do you want a customized title? I don't like it, but I'll show you what it looks like. I'll put Wendy's test report. And then this is where you can save the logic. So if I think this is a report that, hey, I might want to use weekly or monthly or again, I can say yes. And then I always start my reports by my initials. So I put my initials and then I put, this is a patient insurance report. Something like that. Okay, now that I saved it, then I can include all patients and browse. And then we see what the report looks like. So it tells me the patient's name, the chart numbers. Okay, these people don't have Medicare, but these 2 people have Medicaid. And again, there's another column. So if I print this out, I can see, did they have Medicare, Medicaid, or private insurance? So these people had nothing. This has Medicaid, private insurance. And it goes, I can go to the last screen and it'll tell me there's a total visits for 45. And then I had this many patients, 34. And it just tells me I could go through and see how many had Medicaid, Medicare, private insurance. I just have to add them up. Now, if I like this, the next time I run this report, I go to date range, I pick my date range again. But this time when it says, do you want to use a previously report? I say yes. I put my initials. I don't have to remember what the name I gave it. Just put my initials, and then I just have to recognize. Okay, yeah, I remember I called it this. And then all I got to do is just print it. Oh, shoot, I forgot to show you what the title looked like. You can't even really see it. include all, and browse. So you see, I don't have to retype all those combination of numbers and details and stuff. So where it shows you the customized name, it's right here, Wendy's report. If you forget to look for it, you'll miss it. That's why I don't tend to put it in there, because it's just like, yeah, it's just kind of in the other garbage. So if you want to put it in, that's fine, but it's one of those that if you like it, but it saves you from having to put in all that logic again. Now, if you don't like the report, maybe I say, this isn't helpful, this isn't what I wanted, I don't want to do it. Then I just go to the manager utility reports, or the manager utilities. Remember, I told you you can delete these. So you just go find that DRD to delete. And then again, remember, just put your initials and then find the report. So in PCC and all places, I have other kinds of reports I created. I go find the report that I created, which is this one. And it says, are you sure you want to delete it? You say yes, and then it's gone. So it's one of those things, again, I wouldn't be afraid to show you those reports. I mean, to create reports, you can always go delete them. If you don't have the security keys, just tell someone, hey, go delete this report, or walk me through it and I'll show you which one to delete. But it's really easy to delete reports once you create them. Now, if you want to go into, like I said, you should be able to run or capture the reports and put them into what do you call them, Excel, and to put them in a graph. So you could do that with let's do it with administrative records. So let's do it with we'll do it with the categories, SPRC. So I'm going to do a date range, take all visits. I'm going to do primary, secondary. I'm going to do list. I'll do 50. Include all patients and browse. Actually, before I get here, when you get to print and browse, this is where I tell you to stop and then start logging the session. Some call it logging, some call it recording, but you're basically recording the screen. And so the system says, okay, well, record it. Where do you want it to save to? So I'm going to save it on my desktop as a session file, and then just hit save. And it's now recording. So now I can print it. There's my report. Now that I'm done, I can stop the recording. Then I can look on my desktop, find that session file, open it up. I use Notepad, and then there's my report. And so it's pretty easy to run that report. Once I taught my boss I could do this, she was like, Wendy, I know you're at home on sick leave, but can you go into the system and run this report and email it to me? And I was like, okay. but this is fine because there's no patient identifiable information, you know, it's just kind of workload or stuff like that. But, you know, you definitely don't want to do this if there's any PHI, you know, sensitive stuff. But you could technically run this report and send it in a file, change it to Word or whatever, and send it over to whoever you need it to. What I normally would do here is then go and edit it. If I wanted to put it in Excel, to put it into a graph, I would edit and clean it up and then save it. And then all I have to do is then open up Excel. They have Excel? Yeah, they have Excel. I think they have Excel. Did I miss it? Publisher. There it is. And again, if you know, ask me later. If you know Excel, how to go do the graphs, I can go and get the data. I can insert it from text. And it'll say where you want to populate it from. Go to desktop. Sometimes you got to do all files. And then I find that file, import it. Start at row 2. Next. Make sure the columns are all there. Okay, and finish. That's fine. And it pops it in. And then I can go in and I know this was like time at that. It. And I know this was the code. I just want the count. And then I can just go ahead and just graph it. Where's my graph? So you can see how I took that data and you can give it a title. You can make it, I can put the percentages of the counts. You can make it its own little page and put it in a PowerPoint and say, this is the percentage of our psychosocial problems, our socioeconomic problems. I could have done it with our top 10. You can do it however you want. But again, sometimes looking at a RPMS report is not that, but I put it in a graph, it looks a whole lot different. It's presenting the data in a whole different way than just showing you numbers. So, but that's why I find it easier to do it in a terminal emulator, because one, you're able to record and capture the report you ran, save it, and then if I need to, you just cut and paste into a monthly report, or I can then throw it into a graph with Excel. That then allows me to present the data in a different way. And then you just find somebody who's really good on Excel. Because I think I used to work at one time, before I joined IHS, I worked at the Phoenix Children's Hospital, and they were great because at the time I was going from IBM to Windows. And so they sent me to all the classes in Excel and Word. So but that was way back then. I haven't kept up with the updates, but it was great that that was part of my new employee orientation, was to learn all those Word applications. And there are instructions. There are instructions in my training manual. So again, if you go to my website, so this is the behavioral health website, we have training. And so there's the user manual. That's the user manual that has every kind of report that's listed in our system. But we also, in addition to our user manual, we created training reports. So there is a training report for behavioral health reports. And we didn't include all the reports, but we kind of did the more frequently ones that we felt like people might use. So like here is, this is a tally, depression, it tallies the reports with the depression screenings, and this is the logic for that. And then it kind of shows you a screenshot of what that report looks like. So we kind of do that. But at the end of this report, it has those lists, and it has the instructions of just what I did, how to go through Excel, how to capture it. So that's in the back of our report, how to capture it in Terminal Emulator, and then how to pop it into Excel and do the graph. And then it has kind of has a list of, because this is how we used to train. We used to train, and then we would say, okay, here's your exercises. Everyone try doing one of these, and I'll walk around while you do this, when we did the hands-on training. But this is, if you do want something kind of handy, at least that if you learn by reading, this is kind of the manual I would encourage you to download. And it's on our training, on our website. Okay. Are there other questions or other reports people might want to see? I know I make it look easy, but that's because I've been doing this for 23 years. So I tell people I can do this in my sleep, but it's just I've been doing it a long time. It's definitely not, it's something, again, I tell people the more you do it, the more comfortable you get, the more it becomes, when you start to memorize the process and the steps. But it's just something you have to get in there and start doing and trying and playing. And like I said, for me, this is kind of, for whatever reason, it was really easy for me to pick up, and I started teaching others, and then I started teaching other people at other sites, and then suddenly I started doing national trainings. But not for others. My boss was a psychiatrist and internal medicine doc, one of the smartest people I know, but she could not run a report to save her life. But that's why she had me. She was like, Wendy, you're just going to run all the data and just tell me what I need, or give it all the data I need. That's fine. We worked good as a team. So again, sometimes this makes sense to people and sometimes it doesn't. So it's definitely one of those. I'd find somebody. If you haven't seen these reports, again, these depression, alcohol screening reports, I do think they're helpful. If you want to see, especially if you're tasked with, you're going to have an audit and you want to know who had positive screenings, did you do the follow-up? Running these reports will help you to at least make sure there was follow-up, or there's documentation in the notes that, hey, you offered services and the patient declined. You can run these types of reports. And it does ask you, do you want to include information from PCC? So when it says PCC, think EHR. Do you want to include all the visits, so that if EHR had a positive depression screening, you want to see it? So I normally say yes, because I want to see everybody in the whole RPMS database. Was there a positive depression screening in this date range? I can say no. I can include all and browse. And it's going to take a second just because it's a lot of data. It's pulling that. So in this database, again, it's a test database. We had 42 people screened. Negative, there were 7 positive, and then again we have the scores for the PHQ2, PHQ9, and the PHQT is the teen one. So again, it has those scores by gender, males and females, by age. You see some weird stuff, like how do we screen a 1-year-old? That's because it's a test database. People pick things. Who did the screening? So this would be a red flag to me, that who's unknown. Somebody's set up in the database as unknown. That should never show up. What clinics were doing the screenings? I remember during like domestic violence month, I would run the report for domestic violence screenings, and anyone who had over 100 screenings that month, I went and took cookies to that department to say, hey, you guys did good. You're doing good domestic violence screenings. Thank you. And so, I would try to do some identification, or I'd go to emergency department and say, you only did 1 domestic violence screening. Can we do a training? Can we do an in-service? Like maybe you should, be doing some more screenings over there. So that's where sometimes I would run this just to see if there were services or things that maybe I can work with the other clinics in the hospital. But yeah, it's just a screening report. So it really just depends on what kind of data you're looking for. Any other questions or anything else someone would like me to show or demonstrate? My recommendations is, 1, if you feel like you have the need to know in your job duties and job description to run reports, make the request to your supervisor. I would like security keys. And remember, in that PowerPoint, I gave you the security keys. There's the DV reports, the suicide reports, and the general reports. There's 3 security keys. A request for those security keys. Then once you get access to it, then, then start getting in there and playing with it. And then if you have questions, email me, call me, or if we need to set up a call and I will walk you through it. Again, start picking a couple reports. Even if you run that error report once a week, it's getting you in the system and getting you familiar with the commands and how to navigate into this roll and scroll environment. And then you can start trying to run reports. The other thing is, if you run, let's try to see if I run a case report. So if I go and run a tally, I want to just see how many cases have been open, closed, a TCD. And so I do my time frame, all providers, include all, and browse. And you get this. Well, I know that we've opened more cases or we closed cases, but that just tells me we're not using that functionality, that's not being documented. So then that would be something of, well, if we want to run these types of reports, we have to start doing the documentation of how to close, how to open cases, so that we can then have a duration of care. Do we see clients for 3 months? Do we see clients for 2 years? What is our duration care? But we're not going to know if we don't use that open and closed. So part of this, if you run reports, you're also going to probably see where data is not being documented. But that's where, if you want to do a performance improvement or a quality and assurance activity or project, that we want to be able to start capturing this data. We got to document it first, but the reports are already there for you then to start be able to collect that kind of data. So that would be my other thing, is if you do see it, don't get frustrated. It just means you have to go back to the beginning of where is it clinically documented so that it hits the reports. Other questions, examples. If people have a report they have to run today or this week, I can tell you what I would think or what I would try. Nope. I will tell you, I always tell people, if you can get the skills to run this report, you can run reports in PCC management. You can go into the scheduling reports and run reports. You can go and build third-party billing reports, because all the apps, when you go to that core menu with all these applications, case management, diabetes management system, every application has reports in it. And so, and they're all built the same way. They all have a start date and end date. You know, they basically are built the same way. So if you can kind of get the skill sets to run behavioral health reports, you pretty much can go into any of these other applications and run their reports, because they're all built with the same type of workflow process logic. That's a skill set that you would be getting to be able to help other departments as well. But that's all I have. If there's no, I can stay on the call later. If people want to stay on or ask other questions, I'm happy to stay on.
We do have another question. Oh, sorry.
Yeah.
We have another question in the chat. Can you show us an expert report?
Yes. Okay. So I'm going to jump. In RPMS, you do have the ability sometimes to jump to a certain menu. If you know what the menu is, you just have to do a Shift-6 to jump. So the expert is in patient listings. I'm trying to think if I have any data. I hope I do. So it's called the export report, SBRT report. And again, the logic is you got to have the screening, a positive screening, and then you have to document it, the brief negotiated intervention, and then you had to do the referral to treatment code, which is, I think there's CPT codes for that too. So as long as you meet the logic, let's try a year and see if there's anything. I'm going to do all genders. Would you like to restrict the port? No. And I'm going to do all and any providers. With, without, let's do 2, let's see if it shows. We'll do it by patient name and include all and browse. So again, the canned reports just ask you questions. So this one I have, there was 14 that were screened. It tells me patients screened positive at least once were 4. So that also tells me that we use the same demo patients, because there's only 4 that actually, there are only 4 patients, but they were screened multiple times. And then this tells me if they were screened and they had a brief intervention on the same day. This one says there was a brief, if there was one on the 1 to 3 days after, 4 to 7 days after, patient screens and referred to treatment. And then it would give you, if you wanted the list, you would have the list. Let's try a different date range. See if I can do bigger. Let's do 3 years. Do today, all genders, no, all providers. Let's try 3. And let's do it by and include all. There's a few more records. And still, just because it's a dental database, that's why. This time, these are the patients that had a positive screening, but they did not have any kind of intervention or referral. So if I was doing case management, I might want to go do a chart review of these to see. So this one tells me they had a CAGE score of 2 to 4. This one told me they had alcohol screening result of positive. So it's just telling me, so I would maybe look in the note to see, was there a referral? Was the patient declined? Was there just maybe education done? Or was there an intervention done, but they didn't document in a way that gave them credit for what they did? And that's what we're finding, that people aren't familiar with the GIPRA logic. And so they don't necessarily, they might document it in the note, but unless you're hard coding it with a CPT code or education code, if you're not coding it in the right way, then you're not getting credit for the services that you're doing. And so that's why I tell people, if you're not meeting your GIPRA measures for the expert measure, go to the website, go to the CRS logic. And if you're not familiar, you can go to Providers Health Information Technology. And it's the clinical reporting system. And the clinical reporting system has the logic for all the measures. So I can pick this one, and this has the report with all the measures. And then I just need to find the expert. So that is, it's on page 91, okay. So 91 is telling me, okay, so it's telling you who the active people, who we're targeting for this. It's active patients 9 through 75. So that's kind of the group that we're trying to look at. And then here's the alcohol. So we're looking only for an exam code, a CAGE score, a diagnosis of alcohol, and these CPT codes. Or if you put in a score for your audit C, or the craft. That's what's going to get you credit for the screening. And then if it's, there's some other procedure codes, if you're by chance using those. Whoops. And then it's going to do, here's the education. If you did education, if you did, positive results, and then it's going to go into, did they receive it? And again, it tells you, it breaks it out by the same day, 1 to 2, 3 days, 4 days. So then you get into the BI, BNI. So you have to use one of these CPT codes that shows that you did a brief intervention and negotiated the BNI, BI, or you used an education code, one of those codes. And then the referral to treatment is the AODTX. So one of these, this is basically the logic. And so I told people either create a reminder dialogue in EHR, a pick list in EHR, or in behavioral health. Once you use these, they'll show up in your most frequently used CPT codes or education codes. So then you can click on them. But that's if you did any kind of referral or you did any kind of intervention. But that's what the report is looking for, to give you credit for those services. If you just write it in your notes that you did it, you're not going to get it credit, because there's no way for us to search through the note to see if you did it. But that's on the clinical reporting system website is the logic. And we might be updating this. I know I have a call later today to see if we can update that and get this logic to make sure that we're getting all the codes that could give you credit for. So I know that's something I'm going to be working on soon. Okay, there was another question. Do you have any recommendations on who should not be granted security keys? This is going to vary from site to site. I will be honest that I promote integrated behavioral health. So I believe the more sharing of data is needed for continuity of care, for best care, for not stigmatizing and so forth. What I do is I would do a consent form. So every patient who comes to a medical center, I would say do that 42 CFR consent, whether or not they're doing the alcohol services, so you're getting yourself covered for that. I would also explain to them that you're an integrated healthcare system, that there are no records. Everything's in one medical chart. There are no suppressed records or separate charts. How other facilities if you do access any, we don't keep separate charts for HRV, for behavioral health, all the different categories that some places do keep separate recordings or suppressed records that your site doesn't. It's integrated. With that being said, then you would give people on the need to know to have the keys or to see the records. If you do, I'm assuming you probably have some confidentiality concerns if you're using the behavioral health system and not in the EHR. So then if you want to, you're absolutely going to give clinicians, your behavioral health staff, the security keys. You might want to give the HIM person, your medical records person, because if they have release of records, then you as staff don't have to do it, that person can go through the normal medical records process of releasing records. So that might be medical records people may have a need to know. Your IT people, if you lock me out, I can't troubleshoot. You call me and say, this is not working. Well, I don't have security keys to go test it. So your IT people might need to have access to your system just to troubleshoot. Same thing with the coding queue people. Minimally, they need this one to be able to review the visits to make sure your coding and your documentation's up to par for that code so they can bill. So that's a key I normally recommend giving to the coders. But I have also found, because we used to have people prescribing, putting justifications of why they did this medication versus not this medication, or the patient verbally said they were taking this and this. So I've had recommendations to give maybe to the pharmacy supervisors or nursing supervisors. If there's an inpatient or someone coming through emergency, that at least the nursing supervisor has access to this, that can do a quick review to see if there's anything that's pertinent to immediate care. So those are all the situations that when I worked at Phoenix City Medical Center, we kind of had discussions of who should have access to security keys. And I ended up giving it to some of the coders. There were specific coders that did behavioral health coding, to supervisors, nursing, pharmacy, and medical records. Those were the people, and the IT people were the people that, now it could be larger. I mean, it could be maybe your medical director needs to do competency and peer review on some of your staff, you know, so I don't know, maybe they need and haven't access, and there could be other reasons, but those are going to be local decisions you need to discuss. And then you can always go into, if you ever are curious, your IT person, you can at any time go to your IT staff and say, I want to know who has access to our system. And I can go into, I think it's menu management. I can go into keys, and I can run a report to see list users holding a certain key. So I can come in here and I can say who has the AMH I want the reports. So let's see the report 14. The reports key. Oh, AMH. AMH, whoops, the RPT. And then boom, I have a report of every single person in my database who holds the security key. And then I used to run this once a year, and I would run it, and then I would just go through and I would like delete people. And then I'd give it back to the IT people and say, remove these keys because they have no reason for having those keys. I don't know how they got it. They should have come through me and requested it. I should have said yes, but for whatever reason, take their keys away. And if they have a need to know, tell them to call me. And then I'll ask, why do you have a need to know, and run these reports. So you can anytime go ask your IT staff to say who has these keys. It's a pretty easy report. What I find is some sites get a little lazy and they clone people. So when I turn in my resignation and I leave and they hire someone to take my job, they sometimes, instead of creating a brand new account with all the security keys this person needs, they just clone and they say, set this person up exactly with the same keys as Wendy Wisdom. And then they assign all the keys, whether they need them or not. And so they call it cloning. And that's not recommended. What we recommend is actually sitting with the person and saying, do they need scheduling keys? Do they need reports keys? Do they need that? What is it they actually do in their job? And then that way you create that account based on their specific needs, not cloning somebody else. So that's what I found was people got this key during the year because I ran it every year and I'd find new people. It was because, oh, we probably cloned so-and-so and they have access. Well, that was that special person that I gave access to, but this person doesn't need it. So it's a way to management. It's a way, and it's like I just showed you in less than a minute, you can run a report to see who has keys. Anything else? Any other questions? Okay. Well, I know it's a lot of information I gave you. Again, it's recorded. I can send you guys the links that I showed today. So maybe you can share them in an email, and feel free, please don't, again, I'm a social worker at heart, so I never say no to people who ask me for assistance or help. And again, if I'm not the best person, I'll send you to somebody else that this person's better at it than I am. So definitely feel free to reach out to me if you need more further assistance.
Awesome. Thank you so much, Wendy. I went ahead, Odeary put the survey in earlier, but I just put it in there just so it's at the top of the chat. If you guys could just fill out that survey at any point in the next day or so, that'd be awesome. And again, Wendy, thank you so much for helping us start and end our RPMS training. We really appreciate it. All right,
Thank you.
guys.
Anytime.
Awesome. Well, thank you guys, and we hope you have a great rest of your Tuesday. Thank you.